Welcome everyone, and thank you for joining us. Use Zoom's Q&A button to submit questions to our speakers. Our program will begin shortly. Thank you.
Good evening and welcome to tonight's webinar. I am Dr. Iorio, the Dean of Continuing Medical Education at the New York College of Podiatric Medicine. I'm pleased to welcome you tonight to our continuing webinar on continuous diffusion of oxygen. This evening's topic, the consensus on topical applied oxygen, the latest research and where to incorporate it into clinical practice, will be provided by three of our speakers. Our first speaker will be Dr. David Armstrong, followed by Dr. Alisha Oropallo, and the moderator tonight will be Dr. Agarwal. This webinar is a joint venture with the New York College of Podiatric Medical Center as well as Affinity CE. New York College of Podiatric Medicine is an approved provider of CE in the podiatric medicine by CPME. This event is estimated to be 1 CE/CH hour. Affinity CE is our continuing contributor who will be responsible for giving the 1 credit hour to physicians, physician's assistants, nurse practitioner, and nurses. This activity tonight is sponsored by an educational grant by EO2 Concepts. Our first speaker this evening is Dr. David Armstrong. Dr. Armstrong is a professor of surgery and co-director of the USC Limb Preservation Program. He is also the director of SALSA, which is the Southwest Academic Limb Salvage Alliance at Keck School of Medicine, University of Southern California. He is director of USC Center to Stream Healthcare. Welcome, Dr. Armstrong.
Ladies and gentlemen, it is such a pleasure to be with you today. I'm David Armstrong. I'm a professor of surgery and I direct our limb preservation program at the Keck School of Medicine in beautiful, sunny Southern California. Even when it isn't sunny, like today, it's still sunny here. And ladies and gentlemen, we give away all our slides. I would just ask you to ping me or tweet at me or whatever you like, and you can just take them, copy them, make them better, and pay it forward. How does that sound? And in addition to that, just in terms of disclosures, you'll see them here, as well as the New York College of Podiatric Medicine's continuing education activity disclosure as well in terms of commercial support for our shindig today. And you also see our learning objectives as well. And there are 3 of them. It is a trinity of learning objectives today. And we hope that you get at least this much out of this, because I will tell you, as someone who is presenting to you, I have gotten at least as much out of sort of going into this sort of area in tissue repair and wound healing, because this is an area that I was exceedingly skeptical about, but have become progressively less skeptical over the years. And that is this technology and topical oxygen therapy. But I'm going to talk to you just a bit about that in terms of the data. You're going to hear from Professor Oropallo, my longtime friend, who's going to give you a lot of not only data, but clinical experience as well. But I'm going to try to give you a little bit of a brief overview on this kind of big idea. And it's much larger than any one specific therapy. But this therapy may likely play a role in this very exciting time that we have, where we have some technologies and some therapies that are actually showing very, very consistent signals that they may be helping people. And it couldn't have come at a better time, because ladies and gentlemen, I don't need to tell this group, I think I run the risk of preaching to the converted, that foot complications in diabetes are common, they're complicated, and they are costly. And that is not just alliterative, it is the truth. If you look at these data here just from last year, we see that in everywhere around the world, we looked at the World Health Organization's global disease burden, and in every region of the world, in every age group around the world, for every disease subtype within the lower extremity around the world, this problem, the lower extremity complications of diabetes, are getting more prevalent over the last generation. And this is happening at a higher rate, not a lower rate. I don't need to tell you all of that, ladies and gentlemen. But what we also know is that every 1 second, someone gets a diabetic foot ulcer. Every 20 seconds, someone develops an amputation. And when you start looking at the data in terms of morbidity, mortality, and costs, it starts to get you thinking, my gosh, this problem is such a huge problem. And it's not fair to compare one terrible thing to another, but let's just do that together kind of as a family and compare all of this to cancer, because we all have family members that have succumbed or have survived, or maybe even we have survived cancer, but we all care about cancer, but very few people outside of our chat today care much about feet or diabetes, and certainly diabetic feet together. But let's just do this kind of as an academic exercise. Look at these data just from this last year. You see, this is an update of another paper that was widely published that we did back about 15 years ago. And if you look at the best available data that we have, you look at diabetic foot ulcers right now, and it's about a 30%, give or take, 5-year mortality rate if someone develops an ulcer. They are at about 2.5-fold greater risk for dying that year if they develop that diabetic foot ulcer. So just by itself. And then you see these other problems like major amputations, chronic limb-threatening ischemia. They are at least as bad forms of cancer in terms of 5-year mortality. And I think the big idea here is that this hasn't been communicated as such, not just importantly to our patients, but to policymakers and our other colleagues in other specialties. And one other thing is, as we heal these patients, I think we have to ask ourselves, are they really healed? Let me show you this manuscript we had in the New England Journal not too long ago, where we looked at, again, the best available data around the world from our team and from other teams. And look, after healing folks, you have to ask, are they really healed? Because at 1 year, about 40% are going to have another ulcer return. That's about 2/3 of patients at 3 years and about 3/4 or so at 5 years. So, ladies and gentlemen, recurrence in this population is not only common, it is darn near likely. So if the foot is a little bit like, in diabetes, is a little bit like cancer, which we've just talked about extremely briefly together as a family, then maybe we have to flip the script a little bit and we have to look at the larger picture. And when people are healed, maybe they're not really healed. Maybe they're in remission. And I would offer this to you as a little tip when you're talking to your patient. You can bring up the cancer word, and that's uncomfortable for you. It's uncomfortable for the patient and the family. But then when you tell them there's something you can do about it, because our goal is to increase their ulcer-free days, and we're going to try to make that sore as uncommon, as uncomplicated as possible, then they start to prick up their ears. And instead of checking off the list when you have healed a wound in the operating room or in clinic, and the patient ticks it off his or her list, it doesn't become 11th on their 10 most important things to do in their life. Now, maybe it becomes, I don't know, maybe 8th or 9th. That would be great. That would be a wonderful victory. These patients are in remission. Our goal is to keep them there as much as possible and extend those ulcer-free days. And that's why having tools to treat these wounds and then to help them stay healed and monitor is so critical. But how do we manage these things, these patients and these wounds systematically? And it's really, if you think about it, there are really 3 basic questions that we have to have. And we don't have time to get into these things in such depth, but let's just do it rapidly. The first is really, what are we going to take off the wound that might help it heal? And that's aspects of good quality debridement, or if you're French, debridement, and offloading of pressure. Those could be entire sessions and symposia in and of themselves. After what we take off the wound, it's what we put on the wound that might help these wounds heal a little bit better, maybe a little faster, maybe a little easier, maybe combinations of those. And we will talk just a touch about that. And you're going to hear from Dr. Oropallo about that in some depth. And then finally, how can we, after the patient is healed, increase ulcer-free days, hospital-free days, activity-rich days in remission? If you're talking about a holy trinity there. So those are the big 3 questions that we have to ask ourselves. And let's kind of move on now to that first bit very, very briefly. If we're talking about what to take off the wound, and we're not talking about offloading here, we could talk about that entirely separately. But one of the things that we really need to do, is to talk about inflammation. And, these slow healing wounds, these chronic wounds that we see that sort of take up so much of our time and so much of our patients' time and so many resources are a little bit like a slow running computer, if you think about it. Because, if you have a slow running computer, you're a little bit angry at it because there's all this stuff running in the background and you just want to shake it and headbutt it and throw it out the window. Not that any of us have ever done that. But these wounds are not dissimilar. There's a lot running in their background there histologically. There's a lot of inflammatory cytokines and chemokines that are exogenous and endogenous. And they're just making this big witch's brew, this gemisch, if you will, to get a little Yiddish in there because no lecture is really complete without a little bit of Yiddish, is what I say. But that big gemisch of inflammation is just chewing up whatever you put in the wound before it's had time to work. It's like you can't even start up a software program on your computer or an app because there's so much running in the background. So what do we do if that app won't start up? What do we do if there's a slow healing wound? Same thing conceptually. We gotta get rid of this histologically hostile environment, and then we gotta just hit the reset button and hit Control Alt Delete. And surgically is very, very similar to the Control Alt Delete that we can do kind of functionally on our computer. And while that computer is booting up, you can add in an app that might be a little bit run a little more consistently and rapidly and snappily. Same thing with a wound. That whatever we put on the wound now will probably have a better chance to help that wound heal as it's moving through that inflammatory phase into a proliferative phase as it's rebooting. That's the big idea. And we've talked about marrying good quality offloading and advanced wound therapy together as an arranged marriage. And the key thing is just do not disturb these wounds. The less that the high-risk patient and the high-risk doctor monkey around with the wound, the better, I think. And if we can have technologies that we can put on that we don't have to remove, along with offloading technologies that we don't have to put on that we don't have to remove very frequently, then we probably have a winning combination, I think, conceptually, as we're developing new therapies. So that was the big idea about question one very rapidly. And the second one, just maybe even equally rapidly, so you can get to a much more interesting, talented and experienced, intelligent, sartorially splendorous person, Alisha Oropallo, after me. And that is, what are we going to put on the wound that might help it heal faster, easier, or better? Technologies here. We don't have time to get into all of these, but the big idea here now is not to look at each one of those categories that have data to support them, but this one. Now, topical oxygen therapy has now become its own category of therapy very rapidly, even though it's been around now for about 50 years. I think just in the last 4 or 5 years, there have been several randomized controlled trials that have come out that have really brought it to the front, which was really surprised some of us, because, when I think about topical oxygen therapy, I have to say, wait, what is this? Because, in the past, I think I'm on record, and I will be on record again as saying that, I said to myself, and I said, I think on paper and in lectures, that unless someone's leg has gills on them, I'm not sure how, like a fish, that is, this is a fish, even though it looks kind of funny with that proboscis. I thought to myself, gosh, I don't know how topical oxygen therapy is really going to physiologically work. Now, I was aware of some of the data then out of the Ohio State University from my friend Chandan Sen and coworkers and others that had shown that indeed the skin does respire, but I thought that was just sort of a side note, and I didn't think it was going to really be very, very effective therapeutically. And it led us not only to think of kind of fish, but it got me to think a little bit of quackery as well, because it just, in the past, topical oxygen therapy had been associated, I think, with the worst in hyperbaric as well, and maybe a bit of quackery. But to be completely frank, I've already said that I was wrong about this, and I will say it again. I was absolutely wrong because it appears that the data for this now have moved in a different direction. They've moved in a direction where they've inquired and interrogated these technologies, and there is a real signal here. If you look at this, which is, I think, the first of 2 or 3, either systematic reviews or meta-analyses of several randomized controlled trials now, many of them rated quite excellent. I think that we can agree that there is a real signal favoring topical oxygen therapy in terms of tissue repair and wound healing. And I think that is really promising, because it's adding yet another tool into our armamentarium where you have these different form factors that might be helping these patients heal on as we kind of move forward into remission. And you see here, you're seeing these technologies moving and being supplanted by newer therapies, moving from hyperbaric to continuous delivery of oxygen and continuous diffusion of oxygen across a wound. And I think that is, I think it's an exciting time as we're seeing many of these things moving forward into an entirely new direction and to new kind of categories of therapy. And chairs and ladies and gentlemen, I'll conclude just with this. I kind of put this in at the last minute because I was reminded recently of a trip I took quite a long time ago with one of my daughters to Paris. I try to take them all with me every time I go on a trip. I figure that's why God made frequent flyer miles, but this got me thinking a little bit. And check this out. So this is the before times, maybe about 15 years ago. And this is the Louvre. And you see this picture here of La Joconde, looks like a little postage stamp of Mona Lisa there. And you see all these people in this big scrum of humanity just in that room in the Denon section of the Louvre, or the Louvre, if you want to put it on really affect. And check this out. I'll just show you here. So everyone's trying to get a picture of that little picture of the Mona Lisa in this room. And this room is filled with masterpieces, but everyone's only looking in that one direction. And one of the only people looking around was my daughter, who at the time, I don't even remember how old she was. She might have been 9 or 10 at the time. And I'm just going to show this to you because it's kind of cool. And she saw, what we all missed. And look up there. This beautiful, as the foot, someone looking after the foot, someone tending to this humble foot, and at the end of the body. And just like in real life, the foot itself gets ignored. And just like in real life, the humble wound on the foot gets ignored, ladies and gentlemen. And it should get you thinking that maybe with a little bit of humility, with a little bit of perspective, when you step back and you really regard all of what we're doing and we challenge all of our preconceived notions, negative ones and positive ones, and challenge them, I think what we'll find is sometimes there's real serendipity and you can really uncover a masterpiece. And I think that's what we've done here, in that we've identified something that may have been right under our nose quite literally all the time. And I look forward to further interrogation of these data and moving forward and hopefully helping some of these wounds heal more rapidly, getting people into remission, maximizing their ulcer-free, hospital-free, activity-rich days, and keeping a few more legs on a few more bodies. Because, ladies and gentlemen, I think that's what we all deserve, no matter what our health, no matter what our age, or what our perception of Leonardo da Vinci. Ladies and gentlemen, thank you so much. It's an absolute pleasure.
Thank you, Dr. Armstrong. Our next speaker is Dr. Oropallo. She is the director of the North Shore LIJ Comprehensive Wound Healing Center. She is currently the medical director of the Vascular Lab of Comprehensive Wound Healing Center, Department of Vascular Surgeon, Northwell Health, as well as associate professor at Hofstra School of Medicine and associate professor at the Feinstein Institute on Medical Research. Welcome, Dr. Oropallo.
Hi, Dr. Alisha Oropallo. I'm happy to be here with you today to discuss the consensus on topically applied oxygen. I'm a vascular surgeon and associate professor of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell Health and associate professor of the Feinstein Institutes of Medical Research at Northwell Health. I'm also the director of the vascular surgery department and medical director of their vascular lab and co-chair of our Northwell Wound Symposium as well. If you have any questions, please use the icon at the bottom of the screen to ask any further questions that you might have during this talk. These are my disclosures. The learning objectives of this talk is at the conclusion of this activity, participants will be able to describe how oxygen works in wound healing, outline the effects of continuous diffuse oxygen therapy, and list the impacts of topically applied oxygen on wound healing. So how does oxygen work in wound healing? So sometimes it's better just to kind of go over the mechanics of that, and that's discussing the rates and quality of mechanisms that are proportional to the oxygen levels in injured tissues. And oxygen actually is a boost of vitality and support of the demand in wound healing. It's necessary to increase the cell energy and metabolism. It also invigorates cell growth and wound closure and increases collagen deposition with increased repair, up to 460% faster closure rates than just the standard of care of moist wound therapy alone. It also has rapid pain relief. Over half of the patients experiencing increased levels of oxygen will have an increased reduction, over 75% reduction within 4 days of pain. And that significant pain translates into a variety of wounds, can also translate into how you feel and how the patient responds to you. So also, oxygen is also involved with wound perfusion. So as you increase oxygen, you have greater wound perfusion. So there's a rate of new blood vessel formation, which is proportional to oxygen concentration, suggestive of increased angiogenesis. So oxygen also enhances our own body's own antibacterial capacity. It creates reactive oxygen species like hydrogen peroxide, and many diabetics do not have, or patients with diabetes do not have this type of entity at high levels. So oxygen can help assist in that type of reactive species that's necessary for the cellular metabolism. It also, oxygen increases a better appearance and strength. The tensile strength is improved with the oxygen therapy, as well as better collagen organization and reduced scarring. So there's many different types of delivery systems, and you may be familiar with some of the pictures that you see here, some representing different levels of topical oxygen, and others are hyperbaric oxygen. And there are differences between all these different types of technology. These are not all the same, even though they deliver oxygen. So the effect of oxygen is dependent on its concentration. So oxygen is involved, as we learned, in many different pathways, including enzymatic pathways. And the rate of reaction is proportional to the oxygen concentration. The effective healing mechanisms can include ischemic wounds, oxygenated wounds that can improve or accelerate the healing rates. And then topically applied oxygen has its own inherent direct local application, and it's not reliant on the underlying local capillaries. It diffuses directly right into the tissues, and it can be applied continuously to support the physiologic demand, otherwise known as continuous diffusion of oxygen. So I recently published a paper in collaboration with my colleagues about the biomolecular level of oxygen. And this was a narrative review demonstrating that oxygen therapy, no matter how it's delivered, directly affects the biological pathways and enzymatic processes, thereby affecting clinical outcomes. So CDOT like TOT or topical oxygen therapy, does not depend on the underlying capillary structure of the wound bed. However, unlike topical oxygen therapy, the CDOT of oxygen resembles the physiologic oxygen delivery. So the benefit of the presence of oxygen in wound healing is consistent from the biomolecular standpoint, regardless of its delivery system. So evidence shows that supplemental oxygen does increase significant levels of cellular metabolism, angiogenesis, stimulated growth factor signaling, increased collagen deposition, respiratory burst, cytokine production, MMP modulation, and the overall resulting in wound repair, which is what we want. There's also growth factors and cytokine stimulation in the proliferative phase, and you can appreciate the list of molecular biomarkers that's impacted with CDO therapy. Including over a period of time, you can appreciate the initial effect of CDO therapy may not be as noted during the first week when you have high levels of exudate, but then over time you can appreciate the increase in cytokines and growth factors as you would expect this physiologic response for wound healing. So our introduction at Northwell to CDO therapy really took place during the COVID response in March 2020. At this time, as you know, everyone was experiencing challenges within their hospital system and being able to take care of patients with wounds. And many faced shutdowns because they were considered not essential to treating patients, and only hospitals were the essential facilities to treat these patients. However, many patients ended up not being able to be treated unless they had some sort of modality, especially in hyperbaric oxygen therapy. So this kind of catapulted us into a different kind of realm to use CDO therapy to help assist our patients in maintaining the care, if not improving the care that they had, to better wound healing and prevent them from hospitalization. So it was necessary to incorporate a lot of different modalities to get these patients started. However, we had to look for patients that could self-administer the CDO therapy at home, or maybe in conjunction with a home healthcare aide, or maybe in conjunction with their nurse or a family member. It required some remote patient monitoring, and also they had to transfer their images to us so we can monitor that over time. And then the compliance was an issue. But overall, the purpose of this was to keep those patients out of the emergency room. So the objective was to treat these wound care patients at home to improve their chances of being readmitted, and to prevent the deterioration of the wound, and to continue the continuity of care. So CDO therapy was provided to patients that could not or would not come to the wound care center for treatment. Although our wound center remained open, we tried to reduce the rate of patients coming to the wound care center only upon necessity. And so many of our patients were seen via teleconference or telehealth. And we used a digital platform to be able to visualize the wounds, not only conduct the teleconference, but also receive images from the wounds that were calculated digitally so that we could determine the percent of granulation tissue, the percentage of the dimensions of the wound for further assessment. So we had in-services with our home care nursing support and instructed them on how to use CDO therapy. We also followed up with the nurses and the patients as they did their dressing changes. The overall performance that we assessed was 29 patients, which were diagnosed and set up on CDO therapy. 27 patients demonstrated significant reduction or closure. Of the two that didn't, both were hospitalized within 2 to 3 weeks for ongoing unrelated conditions. This pilot study is still ongoing and the results are not final, but I'm going to share with you some of our interim results, which were 9 of the 29 patients that were hospitalized within 1 month, 5 were for reasons not related to the target wound or CDO therapy. And between 64 and 82% of wound closure was seen with CDO therapy within 1 month. This too had less than 2 weeks of CDO therapy prior to being hospitalized for an unrelated issue. And 4 wounds that were related, yet not related to CDO therapy, they all experienced significant closure greater than 80% with CDO therapy before hospitalization. 2 patients had failed stents with 50% stenosis. 1 patient had acute osteomyelitis that was omitted, and 1 had gangrene, however, still closed the wound within 88% in 124 days. So our conclusions of this pilot study was that CDO was effectively treating 27 of 29 wounds at home using concomitant use of telehealth with a significant closure rate. And 2 patients that weren't effectively treated had less than a 2-week treatment before hospitalization with an unrelated issue. So no patients had been readmitted for any complications thus far using CDO therapy. This is a case study, more specifically a 94-year-old male with a non-traumatic wound, history of gout and hypertension. He presented with a blunt injury of the wound, hit his leg on the furniture. It happens to all of us. And especially we see a lot of patients like that, traumatic injury, aging population, very difficult to heal. Call us, what can you do? I don't want to go to the hospital. So he was previously attempted, with an antiseptic solution with his nurse, some compression therapy. And when we first saw him, it was within 75 days when we started the CDO therapy. And then we managed the wound initially with the exudate with the skin prep and calcium alginate. The pain level was quite high initially. And the flow rates of CDO therapy was 8 cc's per hour throughout the treatment. So the initial wound measurements you can appreciate here were 5 by 2.7 by 0.2 centimeters, clean granulation tissue. You can appreciate here a good candidate for CDO therapy. And over time, over the series of weeks, you can appreciate a decrease in pain as well as a decrease in the wound measurements ongoing to healing. Another case study involved a 91-year-old female. This was a more challenging during the COVID pandemic. She presented to us with a wound age of over 300 days before we attempted to use CDO therapy. In this case, she would have been a good candidate for hyperbaric oxygen therapy. However, during the pandemic, we could not treat her for that. So besides her past medical history of sarcoma, basal cell carcinoma, esophageal cancer, she had this large tumor, sarcoma of her right arm, in which it was resected. And subsequently, it never fully healed. And because she had a concomitant soft tissue radial necrosis, all the modalities that she she had fulfilled, which surgical debridement, antiseptics, enzymatic debriding agents, none of them helped close this wound. And she was really worried about her immunosuppression and how the possibility if this wound doesn't close, she may end up in the hospital. So there was a decision to initiate CDO therapy. And on 4/29/2020, the wound size was 3.2 by 1.2 by 0.6. She didn't have much pain, and the CDO therapy was at 8 cc's per hour. And you can appreciate every 2 weeks, we're looking at her wound, and it's making a slow progress, but it's making a progress towards healing. 2-3 weeks afterwards, you can see significant closure rates, and then subsequently, over a little bit over a month, now she's healed with just a scab and no drainage. So the third case study involves a 45-year-old female with a history of obesity and abdominal surgery. And we often see that quite a bit. And she had a prior failed flap, and she did not want to come to the office. So this was all performed through telehealth. And her initial wound dimensions were 3.7 by 1.4 with a depth of 0.2 centimeters. And you can appreciate over the next 21 days, significant wound closure rates, as well as to 91 days until final closure. She was very pleased with her results. And, you know, there's a distinction between both therapies, and sometimes we often get confused between the two. But hyperbaric oxygen candidates, there are specific indications, and of course, compliance and whether they can tolerate the treatment. And it also is more efficacious in patients with Wagner 3 and 4 scores, whereas CDO candidates often are relegated to the failed HBO candidates, or those that are unwilling or ineligible, and more efficacious on 1 and 2. However, that's not the case. CDO candidates can be utilized in other circumstances and have a variety of different indications for their use. Topically applied oxygen has direct and significant impacts on wound healing. As we discussed, it increases many different growth factors, angiogenesis, proliferative phase of collagen deposition and wound healing. Pain management improves, increased granulation tissue. The evidence demonstrates that CDO is very efficacious. And not only is it efficacious, it's also reimbursable in some states, and it can be used as adjunctive therapy for those clinics that can't provide hyperbaric oxygen, or that do provide hyperbaric oxygen to help assess, to help improve wound healing outcomes for patients. Thank you.
Thank you, Dr. Oropallo and Dr. Armstrong, for being here. My name is Animesh Agarwal. I'm the moderator for today. Great talks. Taught me a little bit about CDO and your uses. We're going to go ahead and get started with some questions that have already been submitted. And really, this is primarily for Dr. Oropallo. One of the big questions is, as Dr. Armstrong mentioned, he uses it for diabetic ulcers. But do you find that this CDO treatment will be effective for ischemic ulcers or venous ulcers?
And yes, I can comment towards that. We've used CDO therapy in a multitude of applications, not necessarily for, like I mentioned before, failure of hyperbaric oxygen therapy and so forth. And some of them have been ischemic ulcers. However, I would caution the use of it exclusively for ischemic ulcers. Obviously, those patients do need to be revascularized or assessed by a vascular surgeon beforehand to be optimized, so that CDO therapy can be an adjunctive method to for its efficaciousness.
I think you summarized it really well, Alisha. I mean, I think, you know, if someone does not have enough outflow or runoff to their extremity, you know, this is not going to make the tissue spontaneously reanimate, nor is anything. But I think what it is doing is it may be a really excellent adjunct, and I think the data are supporting that, especially as we are seeing more and more patients that don't have, you know, these purely neuropathic wounds. Many, if not most, of our patients now in North America and around the world have, you know, have some element of ischemia. So I think this is something that we're going to be seeing more and more. Great question.
And can you also comment on this venous ulcers?
Well, Alisha, you wanted to speak to VLUs? I can talk
Yeah.
to that too, but go ahead.
Yeah.
Sure. For the VLUs, we have used CDO therapy with improvement of the leg ulcers. Again, you want to caution in patients that have heavily exudative wounds, because CDO therapy initially will have some exudate associated with it. So you want to just place it on accordingly. When you've got the exudate under control, you can certainly use CDO therapy for venous leg ulcers, and you can still maintain the CDO therapy with compression, concomitant compression therapy.
Okay, great. There's a couple of questions here which y'all may or may not. I know we don't have full coverage here yet. One question is how to obtain a CDO unit for home care. And I don't know if either of you have been able to do that or had any issues, but maybe you can, and I know y'all are in different states, and it's a lot of that is based on where you are in the US. So that's one, is how to get one for home care. So do y'all have
Yeah,
comments?
perhaps I think I saw here that Cynthia Gilliam is on, and maybe she has some expertise in that. I think since she works for one of the topical oxygen companies, I think EO2, so maybe they can offer some guidance there. Cynthia, are you able to type any of that in, or maybe you can follow up with some of the people?
Yeah,
if you can.
I'm not sure they have access. They can.
If they don't, no worries. But maybe we can to follow up on that. I will tell you that I've been over the years now. This has been like 10 or 15 years in coming, and as we've been exploring these data, and they've been sort of mounting now, and I've been to Baltimore and CMS any number of times, talking with them about a variety of different technologies, and especially this now. And, I think things are often slow to change, but I think there's just such a tidal wave of data for this and other various randomized controlled trials supporting this. I think we're probably going to see this approved at some point in the future by various carriers. I think the data are what they are. Yeah. And so it's that part's really promising.
So real quick from the company, from two people from there. So it is available in New York City Medicaid, of Veterans Affairs System, and the IHS. To get it for home care, it requires a prescription, and they can follow up with the home health agencies after that. And their clinical staff from EO2 will help train any home health agency out there.
So I just want to quickly add, Animesh, we do use it in New York, and like you mentioned, it is available, and we have in-serviced the home healthcare agency in doing and how to apply it as well. So, but there is a lot of support from the company to obviously train the home healthcare agency and even patients in the application of it.
Yeah, and I think, Alisha and Animesh, I mean, I really think this is where, those are great questions. I think this is really where a technology like this is going to be helpful, is really kind of maximizing, as we say, sort of hospital-free days, and kind of moving our patients from sort of hospital to home. I wanted to ask Alisha, since you've been, you mentioned a couple of these patients, one of the kind of sort of serendipitous findings we've had over years, actually, but even amongst patients in some of these randomized controlled trials, has been mitigation of pain. I can't really explain it, frankly, but it does appear to be really pretty consistent. Have you had that same experience, at least anecdotally, initially in your series? And you want to speak to that?
Yeah, thank you. I initially mentioned it in my lecture, but it's really been kind of a continuum that I've seen, is that the CDO therapy does help with decreasing the pain. And again, it's all anecdotal, but still it does make a significant difference, especially for those patients that are having a lot of pain associated with their wounds.
Yeah, I wanted to comment because I was going to ask you about that, because I've been using it for a while on and I'm an orthopedic trauma surgeon, for those of you that don't know what I do. So I'm in a different wheelhouse than either of my other two panelists here, but I deal with more surgical wounds that may be dehisced or having problems, and they have a lot of pain. And I've tried different modalities to get some of these superficial wound dehiscences to heal, and I have been amazed at the pain relief that they have had, and I'm still scratching my head as to why. And as you know, trying to study pain relief is always very subjective, but that has been the one consistent thing throughout all our patients is the pain relief. So it's good to see that everybody else has that same kind of clinical experience with these patients. So moving on real quick, there is another question. Oh, just for Kate or Cindy, just in terms of what is the cost for the unit? People are interested about that. I'm sure that varies from where you are in the country and insurances, but I'll wait for them, but hopefully we can get you an answer here for that. They are working with CMS to get approval, hopefully all across the country.
And Animesh, I heard from Canada. Apparently, we have Canadians on here too. There's no Zoom sort of moratorium at the border, FYI, there, Agarwal. But I heard here from Phil Aboud, who I haven't heard from in a long time. He indicates that there is home care. I guess Health Canada or must cover it north of the border as well for home care.
Right.
Yeah, well, in New York, we have it again for.
And you border Canada. That may
We
be
do, yeah.
based on my last check of the map.
And then,
at least before the pandemic.
yeah, so someone else also chimed in from New York that it is approved after insurance verification on most, if not all, managed Medicaid programs in New York State. So that's good to know. So thank you, Dr. Ioria, for that. For those of you that need an email to ask some other questions, you can contact one of the reps at info@eo2.com if you have any other questions directly related to the logistics of getting it or payments, etc., and they can help you directly with that. So one question I had for both of you, it sounds like both of you have been using it now for quite a while. So how has CDO therapy, we all have various modalities to help with healing these wounds. You showed a nice slide of all these, 6 different types of adjunct therapies to use for treating. So how has CDO changed it? Has it jumped to the top of your list? If each of you can kind of talk to that, it's like it's become your go-to now, or, where are we with that?
Hey, Alisha.
So I don't think it's changed other standard of care, like for instance, compression therapy. I feel like it's almost an adjunctive method to when you've got that good granulation tissue and you've got a decreased amount of exudate, that's when you can really use the CDO therapy. So it's an application to help expedite the wound healing. However, if a patient has an infection or there's other issues that need to be addressed, for instance, what we talked about with the revascularization, you have to address those issues. So I think that when you're looking for an application of something and when you're at that phase, like the proliferative phase, and the patient's been optimized, I think that's a really great time to use CDO therapy in a wide variety of applications.
And before I have you answer, David, just something that Dr. Oropallo said, because one of the questions is, can you explain how does it work in patients who have venous ulcers and 2-layer compression bandages in place? Are you going to use it in that patient or no? Or how do you manage that patient?
Yeah, you certainly can. And like I said, if it's not heavily exudative, you can place it right on top, and you can even place other applications of, for instance, if you use concomitant alginates or foams, you can place that right underneath the appliance itself. And then you can go ahead and just apply your compression therapy on top. So it really doesn't change any of the modalities that you might be administering to help expedite the wound healing.
Okay. And from the
I think that, yeah,
sorry,
I think
they mentioned that you can use up to 4 layers of compression from a company standpoint in addition to that. So sorry, David, go ahead.
that's all right. No, that's all right. It's like Princess and the Pea with the compression. It's like how many mattresses can you use? You can use up to 4 here before you can't go up to like 16. But that would be but no, I think a 4-layer wrap is like, yeah, the standard. But as regards other, I think what's helpful to understand here is that this is kind of like something of I'm excited about the future because, I think the form factors here for these technologies are, they could probably build on them. And it's almost creating like one of my old friends, Elof Erickson, is a plastic surgeon, just retired from the Brigham, but he created like a wound chamber years ago where he wanted to try to, put different things into it and kind of get feedback from it in terms of, sort of a kind of a closed loop kind of system. This to me reminds me of that, where you have almost a closed environment where you can actually start You can optimize your wound environment. You can offload really well, which we do, with this, if it's even if it's on the bottom of the foot. And I think, there's going to be further iterations here that are going to really make this, better and better. And for me, it's exciting. It's exciting to see these data emerge, for this and other technologies.
So to complete question to you, so has it changed your, have you been using it more often instead of other adjunctive treatments for your diabetic foot ulcers, or is it still kind of the same?
So so the way I use it is like everyone else on here. I'm trying my best to use it within the confines of reimbursement in my institution as well. So we can use it. We use it a lot now as part of our clinical trial program, which is awesome because there are members of our wound healing unit that are kind of evangelical about this, right? Because especially with the pain relief and the tissue repair and wound healing capacity. And I think as this becomes more and more widely available to a broader segment of patients, we're going to be able to use it even beyond that. And for some of our, and obviously also you see for veterans, if you're in the VA and you have aides at the VA and you can treat people, you have that option as well.
Great. One question I had for you, which I was actually surprised, Dr. Oropallo, when you said this, was for me, and I'm not an hyperbaric oxygen expert user or anything like that, but you almost made it sound like HBO would still be your kind of primary treatment for a lot of these patients. And you did say there were certain indications, and then based on your, the classification Wagner 3 and 4, that would still be. For me, I was always thinking that that would be my first line would be CDO. And then if that didn't work, I would go to HBO. So can you comment on that? I mean, you have much more experience with all these, wounds that use HBO than I do. So it was interesting to hear you say that. So,
well, I don't think the cat's out of the bag yet. Things definitely might change. I think that we just have to think about CDO therapy in the back of our heads before we jump to HBO therapy. And those patients that may not be suitable for HBO therapy are certainly, possible candidates for CDO therapy. And I think there's a broader indication for CDO therapy than HBO therapy. So we have used CDO therapy much more than HBO therapy because of the broader indications. So I think that, there's definitely a wide array of application for CDO therapy. And I wouldn't say that I always jump to HBO therapy first, but we do have that available. So if you certainly don't have that available, then I would definitely strongly consider CDO therapy. But if you obviously, based on the trials, randomized control trials, obviously certain grades of applications of hyperbaric therapy would be applicable, in certain types of patients, especially with deeper wounds, and that involve the bone. So, or gangrene. And those patients you wouldn't necessarily use CDO therapy for, especially with gangrene because of the perfusion. So, I don't see that there's a conflict. I actually see it working together to help heal the wounds faster.
So out of that small subset of patients that you presented on, the 29 patients, I think.
Right.
And those are more COVID related, right? So that they didn't have to go. So out of those, and you may have kind of reported on it, out of those 29, how many of those would, if they were willing to go or weren't afraid of COVID or whatever, would have gone to or you would have thought needed HBO therapy, and you were pleasantly surprised that actually CDO did the trick? Did you have anybody like that? You know what I mean?
Yeah, I mean, I would say more than half of them probably would have, made the indications for hyperbaric oxygen therapy. And then it's hard to say whether the patient would really come in. There's a lot of patients that don't come in for all the restrictions of HBO therapy. Yeah. So it's hard to say, but perhaps maybe about even half of that might have come in. So you're looking at, but I was surprised. And that's why I'm here talking about it, because I was surprised that, these patients.
And I think, Alisha, I mean, you're actually talking to, Animesh is in San Antonio, which is kind of the birthplace of the kind of the modern use of hyperbaric, in not only in divers but in burns, at Fort Sam, and then of course at the Methodist, and then at UT Health Science Center. So, but this is a little like bringing coal to Newcastle. But the thing about it is that this is sort of different from HBO therapy, isn't it? I mean, it's fundamentally a different mechanism of action. I made the joke about, gills and things on the leg, because I mean, it's just not, you're not respiring this, and it's not super saturating your plasma. So these are really, these are really not mutually exclusive either, right? You wouldn't like, take someone off oxygen at home because they were on oxygen, or some other kind of, so these are, it's like two different delivery systems. It's, and I think maybe the two could be used together, or maybe, no HBOT in some cases, and vice versa. Don't you think?
I think, Dave, you hit the nail on its head. That's really, they're totally different devices, different mechanisms that we talked about. And I think that they could be used either probably together, or, depending upon what's needed for the patient.
And I think the problem, at least for me personally, and why I was so very skeptical about this up until just the last few years when these data have been emerging, has been that, these things, it looks goofy, right? I mean, you have like oxygen going into something on an extremity, on a wound, and you're saying, okay, where exactly is the respiration happening, right? But in fact, there is a real physiologic effect, and that is, the data are there for that, and now you have all of these randomized control trials and meta-analyses / systematic reviews around this too. Frankly, remarkably more than for systemic hyperbaric, or I should say, although I think they're just the two are different categories.
And then last question, I know to be mindful of everybody's time. So those that do you use it in conjunction with other wound care products? There's lots of things you can put into the wound to help debride it or whatever. Have you been using it in combination or by itself, or where does that come in for you guys?
I've been using it for both. In some cases, some wounds that are a little bit more exudative, I might put something underneath it. And in other cases, I would place it as a direct application.
Okay. David?
Yeah. And we wouldn't think of, like, if we were treating like someone's cardiovascular health, we wouldn't think of like using of not using a statin because we're using a loop diuretic, right? I mean, so I think that we have to get more sophisticated in how we're assessing these things. And this is a whole different discussion though, Animesh. It's really about how we have to have companion diagnostics to tell us when to start this and stop this. For instance, if we were giving someone a statin, we'd test their cholesterol. If we were giving someone a hydrochlorothiazide or a diuretic, we check their blood pressure. But we don't have those readily available now in tissue repair and wound healing. That's changing, which is awesome. But I think that the ability to use this with other things is there. I mean, the form factor is there. We've used it with a bunch of different tissue products, both synthetic and allogenic, and even skin grafts and other kinds of things, regularly. So I don't see this as being if or. And by the way, I think there are a lot of people that we tried this on skin graft donor sites for the pain. Because skin graft donor site is going to heal no matter what you do, frankly. And we use it on the skin graft donor site just for the pain, and that's actually kind of helpful as an analgesic. So anyway, I'm sorry for sucking all the oxygen out of this discussion, so to speak.
My point was that it's good to think of it as mutually, it's not mutually exclusive to other treatments. So
yes, that's it, baby.
So, I think that's the important thing. Last thing is, someone asked about certain pressure and the device. You can change the flow rate as to how much oxygen. So just real quickly, is there a minimum pressure or delivery rate you use, either of you. And you mentioned 8 mils.
Yes.
And so I think most are using 8 to 10,
Mhm.
and we'll leave it at that because I know we're over time. So overall, you can go 3 to 15 per hour. And again, that'll have effects on exudate and everything else. So I'll leave it at that. I'm being told this is our end. So again, both of you, thank you for joining us tonight. We had a great showing, almost 130 something participants. So a lot of people from all over. Again, if you need to use it now, move to Nova Scotia, because we had a lot of people apparently chime in saying they can get it readily and have been using it, which is great.
Or maybe if you're a Newfie, maybe you can go to like Newfoundland as well. So that's another possibility. All you Canadians.
But I want to thank everybody for participating. I want to thank EO2 and our friends there for supporting this activity.